This is a recorded lecture on the concept of immune response as it's related to organ transplantation. You know, transplantation has been around for a really long time. There was a lot of trial and error in the early days, and what would happen in the early days is patients would experience acute rejection. What would happen is the surgeons would replace an organ. They would stand over the organ after they had connected the vessels and see if the organ would perfuse or not perfuse, and that's how they would know whether or not they were going to have a successful transplantation at that point. If the organ turned cyanotic, then they would remove that organ. It wasn't until about the 50s that scientists were able to begin to understand a little bit more about transplantation, and they had some success with twin to twin and then sibling to sibling, and now today we can enjoy non-related transplants because we had the advent of histocompatibility labs, which are able to closely match a donor and a recipient. And then in the 1970s, we had the discovery of cyclosporin, which is a very powerful immunosuppressant that individuals with a kidney transplant usually take to suppress the immune system. So today we're going to talk about just some of the facts about organ transplantation. You know that we have solid organs and we do have some tissues. So when I'm talking about tissues, I'm talking about things like skin and bone and corneas and heart valves. So you remember that we talked about heart valves back in our first 4 modules, and these would be the biological heart valves, which do not require lifelong anticoagulation, for example. The solid organs are heart and lung and kidneys and liver, pancreas, and some intestines. And so the top 3 organs that are transplanted today are heart, liver, and kidney. So there are some organs that you can transplant in segments. For example, you can transplant a liver lobe or a lung lobe or portions of the intestines. And sometimes we do dual transplantation. For example, you'll see a diabetic, for example, get a kidney and a pancreas simultaneously. Things were really improved when, and I don't remember what year it was, when you were able to declare whether or not you wanted to be a donor. And you can do that today through registering when you get your driver's license or renew your driver's license with the Department of Motor Vehicles. So remember that transplantation or donation rather, consent varies from state to state and facility to facility. Now, UNOS is something that you might not have heard of. It is the national waiting list for people that are awaiting a transplant, and they are placed on that list. And the reason why we have this national list is because if you're sitting, for example, in El Paso, Texas, and there's an organ available in New York City, and the patient from El Paso matches most closely to that donor, that organ will be flown to El Paso, barring the fact that it would have to be here in El Paso, it would have to be a kidney, because the only transplant center that we have here is for a kidney transplant. Transplant teams are very highly specialized groups of individuals that usually go from community to community to manage transplants. So as I said before, we have a renal transplant program here, but we do not have any other transplants. So when we have a donor that is on life support and they're going to donate their organs, a transplant team will fly in. Usually they're coming from Dallas, and they manage this patient until the patient goes to surgery and the organs are procured. And so they manage that patient pre-op and intraoperatively during the process, because there are very strict guidelines that must be followed to maintain the health of the organs that will be procured. So one of the reasons I mentioned histocompatibility, Histocompatibility testing and typing was one of the greatest things that is being utilized to match donor and recipient. So you'll hear that many times when we're talking about living related donors. For example, if someone needs a kidney, they'll try to work up lots of family members who are willing to donate that kidney, and what they're looking for is hopefully that perfect match, or at least a very close match. There's a lot of things that go into transplantation. It's not just the organ. You have to think about the psychological impact that it's going to have on the patient, the recipient, as well as the donor. There's also a financial component that people need to consider, which seems kind of odd, but if you can't purchase the lifelong immunosuppressive therapy that's required to maintain the organ, then that can be an issue. So we need to evaluate financial stability and ability to purchase immunosuppressive therapy, or at least find resources for those individuals who may not be able to pay for those medications. And then okay, so let's talk a little bit about the thing that nobody wants to hear, which is called rejection. And we're going to talk about this different types of rejection that are out there. So, you know, obviously here in the United States of America, we only transplant like organisms, which are human to human, for example. So we call that an allograft. And I think it was the Russians who in the past tried to transplant organs from an animal, and I'm sure it was a primate, into humans, and that just didn't actually work. So the immune system plays a huge role in rejection or not rejecting. So remember that the immune system is our defense system, our defense mechanism. It's a function that's in place to protect us against any foreign substance, whether that be a bacteria, whether that be a virus, or our own defective cells that we make. And so that's part of why immune rejection or immune complexes or immune concepts are within the cancer realm as well. So throughout our lifetime, what happens when we come in contact with bacteria or viruses or anything that is foreign to us, the body forms these memory cells of these foreign invaders, and they store them. They store that information in their memory bank in the event that they should ever need to bring out a weapon of defense, because if the intruder ever resurfaces, then they recognize that foreign substance, and then they'll begin to attack it. So that's a protective mechanism that the body naturally undergoes, and we do want that, right? We do want our defective cells to be destroyed. We do want the body to recognize previous exposure to bacteria and viruses, for example. And one of the consequences of that is that it will attack an organ, which is what we do not want when we have a transplanted organ. So that's why it's important that our patients are on those immunosuppressive drugs, because they're going to help to stop the rejection of that organ or the attack of that organ by the immune system. So see, I have types of rejection here. And so really what I want you to know is that we're going to talk about hyperacute, acute, and chronic. And in these three, the host or the recipient's immune system is responsible for starting the immune response and beginning that rejection. So it's the recipient's body who begins the process for hyperacute, acute, and chronic. Now, the last one we're going to talk about is the opposite of that, which is graft versus host, where the organ, the newly transplanted organ, initiates the immune response and is responsible for the rejection. So hyperacute, we don't see so much anymore, okay? So this is where I told you that this is what the surgeons would look for when they had a newly transplanted organ back in the early days before we knew anything about transplantation. So this thing happened immediately. It happens immediately in that situation or within 24 hours of transplantation. So there's no cure available for this. And at this point in time, because of all of the HLA testing that we enjoy today, and the cross matching and the matching of the transplant recipient and donor, has made hyperacute rejections a rare phenomenon these days. Now, acute rejection, it still continues, and it begins weeks to about 6 months. We consider that to be an acute rejection. So what happens is the body forms those memory cells, antibodies form against the transplanted organ, and the natural killer T lymphocytes and the macrophages attack that organ and try to kill it. So in the acute phase, thankfully, this may be treatable for our patients. And how do we treat them? With high-dose steroids or immunosuppressive agents. So and sometimes we use something called rituximab, which is a monoclonal antibody to help suppress the immune system. So now we have powerful agents on top of immunosuppressive drugs that are further suppressing the immune system. And so this is risky. This is very risky because our patients are at increased risk for infection because we are significantly now suppressing that immune system. So as the nurse, it's really important that you're hypervigilant about recognizing the signs and symptoms of infection and educating the patient as well about ways to reduce their own risk for infection. So when I put on the slide, treatment is available, but it comes with a price. What I mean by that is that it comes with those risk factors, and you know that the immune system is super important when it comes to protecting us against foreign invaders, against cells that are defective and things of that nature. So we're going to talk about chronic rejection. And so chronic really is just a bunch of episodes of acute rejection. That's really what a chronic is. It means you're just having episode upon episode, and it can last from months to years. Yes, it's irreversible because you have all of these immunosuppressive drugs that you can give to your clients. So they're going to be naturally immunosuppressed with a drug like cyclosporin, for example, but of course you can add more powerful immunosuppressants like steroids and like monoclonal antibodies. But there's really not a cure for this. What we do is we control and manage these acute episodes, and there are many, and provide supportive care, obviously. And a lot of times these patients will end up losing their transplanted organ. And really, there's no known etiology as to why these acute rejection episodes continue to happen. But what happens over time with the transplanted organ is that it gets infiltrated with large numbers of like white blood cells, lymphocytes really. And what does it do? It injures that endothelial lining of the tissue or of the vessels and of the organs. And so if you remember, the endothelial lining is that very thin, glistening lining. And so what happens is over time, that infiltration will cause fibrosis, and it'll cause scarring and thickening of that vessel, which of course decreases blood supply, which decreases tissue perfusion. And we know what happens when tissue perfusion is decreased. We have a suffering transplanted organ. So when you know, and of course you're going to look at the area or the organ that's transplanted. For example, if a heart has been transplanted, what you're going to see, and then your patient is in chronic rejection, you're going to see an acceleration in coronary artery disease, because that's the vessels we're talking about here. If it's the liver, for example, you're going to lose your bile ducts. If it's your kidney, you usually cause fibrosis of that kidney and glomerular nephropathy at that point. So it's important to manage these types of rejections, if at all possible. But we need to know that the more acute rejections that a patient has, of course, it becomes chronic after about 6 months, and then we do have the risk of losing that organ, and then the patient will go back on the donor list, or if it's a kidney, for example, they might have to restart dialysis. Now, the last type of rejection we're talking about is graft versus host, which to me is like the opposite of common sense. So it's when the organ is going to attack the new host, okay? So it sees the host as foreign. So graft versus host usually happens about 7 days, about in the first week to 30 days. And most often it's seen in a bone marrow transplant, but it can be seen in any organ. So the T cells are going to proliferate. They're going to see the new host rather, as foreign, and it's going to begin attacking and destroying the new host cells. So what will you see in these patients? You're going to see a maculopapular rash that you'll find on the palms of their hand and the soles of their feet, and it's very painful and it itches. You can also have, for example, some liver involvement where the symptoms can range from mild jaundice to coma. In the GI tract, it could cause, for example, diarrhea and abdominal pain, a GI bleed, and some malabsorption could happen if we're talking about the GI tract. One thing about graft versus host is there's no adequate treatment for it. Of course, the only treatment known is the addition of powerful steroids, which of course, again, increases the risk for infection. Now, these patients may need to have, if they need a blood transfusion, what we will do for them is irradiate the blood products. And so what does that mean? We'll put them under a radiator, which is a radiation machine. And what it does is it radiates that blood product, and it decreases the replication of T cells, which you know that's part of what's the T cell lymphocyte is what's going to infiltrate the organ. So we want to reduce the risk of that replication, so we irradiate the blood products. So there's a balance that occurs whenever we're dealing with a transplanted patient. We need to provide enough immunosuppressive agents to prevent rejection, but we don't want to immunosuppress the patient so much that the immune system is not available to protect them against things like infection and cancer. Because if the immune system doesn't destroy those defective cells, we know what can happen. So immunosuppression, again, is a lifelong commitment. That's important to know. And the medication contain this newly transplanted organs comes with significant side effects. So we do need to teach our patients about the importance of lifelong immunosuppressive agents and the side effects that come along with those drugs.